Thanks very much, Debbie, and also to Sages for inviting me to come and speak. So yeah, I have no disclosures to let you know about that are relevant. Moving on from what Debbie has already said about my involvement as a patient advocate, about 3.5 years ago I became appointed to the Association of Coloproctology of Great Britain and Ireland Patient Liaison Group. And we're a group of 8 patients. We're made up of professors, scientists, marketeers, mental health first aiders, co-authors, we're business owners, and we are ex-bank managers. And we are all unique, but we're not different in the respect that we've all had abdominal wall surgery. We've experienced collectively bowel obstructions, chemotherapy, radiotherapy, proctectomies, hernias, pregnancies with stomas, hernia reoccurrence, and a stoma formation. We have a large social media following and we have direct access to patients across the globe. Our expertise and our interests are in bowel stomas, irrigation, hernias, prehab, diet, IBD, cancer pathways, innovation in healthcare, consent, decisional regret. We're a sounding board, we're listening leaders. These are some of the studies that we've been involved in and some of the publications that we've co-authored on as well. So a little example of what we do, we had a researcher asked us what's important to patients when they're in the hospital. So just a little brief example of very quickly got together a SurveyMonkey survey. We put out a 5-minute survey to patients. It went up for 24 hours because we do all this in our own spare time and we were on a time limit basically. We had 152 patients responded. We used social media as our form of dissemination, and we asked patients about elective surgery versus emergency surgery, and we had a good age demographic there as well. We wanted to find out what was important to them when they were in the hospital. So we asked questions about sleep, we asked questions about how likely they were going to be able to raise a concern about their care. We asked what mattered to them when they were inside the hospital. It's no coincidence that they wanted surgeons to be attentive and listen to them, but also they wanted sleep was important to them in hospital. One of the other aspects was, and I tend to see this as sometimes when surgeons or researchers use a primary outcome as length of stay, although it's vital for patients, although it's important, it's not vital. So it might be something that you think about when you use it as a primary objective to your studies. We also had some free text comments about what was the worst things about being in hospital, and that was lack of communication, compassion and privacy. You're not surprised to hear sleep, noise, food and heat. But then there was some things, as if there is such a thing as saying there's some best things about being in hospital, and that was down to you guys, and it's the care and the support, feeling safe, having company and being out of pain. So when I was given the title of this talk, it's important that I, again, don't give you just my opinion, but I get the collective view of other patients. I've never been offered prehab, but I have gone through 4 ERAS programs they only last 3 months in the UK, and I'm still waiting on a proctectomy because of multiple cancellations. I wanted to run a couple of polls, Twitter polls, to find out. It's great to run some Twitter polls because it's instant, and you find that you do get a lot of people responding to it. And generally, it was around the prehab: when should it start, when should it stop, and is there an association between prehab and mental health? And you'll see that some of the responses there from the patients, and you won't be surprised to hear they've not been offered prehab. And it also should never stop was one of the highest votes there. We had some surgeons come on and give some comments on that as well, and that tends to be surgeons who are quite active on Twitter as well. We asked about same-day discharge after colorectal surgery, and we asked about ERAS. And again, the same-day discharge generated a lot of votes with 347 votes on that one. And again, people were never offered an ERAS program. This is what the patients say about ERAS, and this is what is important. And Linda Tutti and Sue Blackwell are both, Sue Blackwell is part of the patient liaison group, but this is what the patients talk about ERAS programs. And Linda Tutti sums it up quite nicely, which is post-operative complications can be absolutely miserable. And to have to sit in an ED department after you've been discharged because you end up with a post-operative complication can be nothing short of living hell. Sue Blackwell is not a fan of ERAS at all. She felt that following an ERAS protocol caused her complications, and had they monitored her as a patient and rather sticking to the protocol, she may not have had those ERAS programs. She may not have had those complications. I think to sum up with that is that patients need to be able to recover better and not just faster. Also asked a question about, and this is probably one of my favourite ones, which is around at what point should sexual function and psychosocial support be discussed and by whom? And again, this will generate a lot of responses from proactive surgeons who are on Twitter, know what the patients are saying, and the patients. And you'll see Frank McDermott, Joga, and Mark Bagnall all saying this should be happening from the moment the patient walks in the door. However, what the patients say is a complete mismatch. So it's at this point I want to let you know about a study that we did. So during lockdown 1, I convened a Facebook Messenger group. I invited 20 patients to this Facebook Messenger group, and I validated them by the length of time that I'd known them, and also their response and trading between patient-associated groups. I asked them what questions. We got real probing questions about what really impacted them sexually after surgery and what were the issues. And once they gave back some feedback, I then invited 2 other patients and we put together a survey. And at that same point, we invited 3 surgeons. We invited Phil Tozer, Rebecca Fish, and Carly Bissett to be involved in our paper. So we used, our primary objective was for it to be a patient survey. And we wanted to highlight and ask questions that mattered to the patients and their partners in relation to sex after colorectal surgery and pelvic floor surgery. We had no ethical approval because as patients we weren't associated with any institution. And we did pay particular attention to the sensitivity nature and the explicit content of the survey, so we made it for strictly 18s and over. We also were able to pre-approved by the patient groups. We signposted the patients who may have had some distress during filling out the survey. We launched it and disseminated it via social media alone, using Facebook and Twitter and the patient association groups. We developed a Twitter handle and paid particular attention to a concise bio and our logo. And we did a few teaser taster sessions before we launched. We put 72 questions together. We put it out on social media for 3 days, and we got 636 individual responses, predominantly from females. We had 14% representation from the LGBTQI community, and the indications for surgery varied from UC to anal fistulas. And for the patients who overwhelmingly, 85% had a stoma, they'd lived with that stoma for between 1 and 5 years. The results followed, and we were quite invasive in the questions that we asked about sexual positionings and what they enjoyed prior to surgery and what they enjoyed after surgery, and due to the surgery, did it cause, and did they have to change the sexual positionings? Overwhelmingly, well, 46% of the respondents reported that surgery had a negative impact on their sex life. And overwhelmingly, the majority of respondents, 74%, said agreed or strongly disagreed with the statement that had been offered advice about sex before surgery. And they also strongly agreed and disagreed with the statement that their surgical team spoke to them openly about this. So these are things that really, this impact on surgery does cause implications for consent. And it highlights the doctor's duty to find out what matters to that individual and explain to these patients the potential consequences of all treatments. The conversation is imperative. Obviously, there was limitations to this study because we were biased in ostomy, so we don't know if it's relevant to people who didn't have an ostomy. We also were predominantly younger women, so again, we don't know if this or what impact it has on older women and men. And so the relevance is unclear. What we do find from this is that the patients would much rather an opt-out of the discussion conversation. So you, as healthcare professionals, universally should opt every single patient, irregardless of age, race, or ethnicity, into a discussion about sexual implications after surgery. As a result of this, we got our paper published in colorectal disease, which is something we're very proud of because it's the first patient study to be published in a prestigious colorectal disease. But then it was really important that we then sent it out so that people read it, because there's no point in us doing this and then making sure it doesn't actually get read. So we just put together a little bit of a A6 card, and because our paper was funded by the ACP, we were able to have open access. And we got a little QR code on the back of this A6 card, and we've slowly but surely disseminated it across the UK to all the colorectal departments that have patients going through this. I'll leave you with this final thought, a closing thought from Jenny Pipe from the Patient Liaison Group. And she says, "Thank you, surgeons, for your skills at saving lives. But please remember that that life that you've saved needs to be lived. Post-operative changes to body shape and function need to be considered with and for the patient with regards to their current life situation." Thank you.